But, I mean, and I know now I'm probably going away from the thalidomide question, but don't you think that there should be health warnings warning women who get pregnant in doctors' surgeries, etc., hospitals, to how dangerous inhalation, how dangerous, I don't know, I mean, I believe that insecticide can be dangerous.
Yeah.
All sorts of different things can cause these sort of abnormalities.
You see, this is the whole complex area of health education. On the one hand, we live in a society where there are an enormous number of different chemicals, be they agrochemicals, or be they deodorizers, or be they things to help foodstuffs survive long after the expiry date on the shelves, or whatever it is. There is an immense exposure to chemicals. And thalidomide particularly has proved to be extremely dangerous, and organophosphorus in agriculture. And if you look at a list of chemicals that have caused congenital malformation and limb malformation specifically, there are several hundred of them. My own personal experience of this was that we used to be keen dinghy sailors, and where we kept our boat was getting overgrown. So I went to a chemist and I got a herbicide, from which time the dinghy park was beautifully kept and just sand and ever so clean. My wife swam in the water. That was 2,3,4-DDD, which was a relative of the American defoliant, which they used in Vietnam, and it was a potent cause of malformation. And I found the bottle in the garden shed a few years later. Fortunately, the pregnancy was normal. But it is this long arm of coincidence that we have to face. On the other hand, people are getting older. There is no indication of all our health being worse than it was for parents or their grandparents. And therefore, warning notices are double-edged. They can cause a considerable amount of anxiety, much of which will be misplaced, because most of us have a normal life and get to ages that our parents or grandparents had no hope of achieving. So in many ways things are getting better. And to terrify everybody out of their wits, it's hard. It's very difficult. Specifically, one should advise pregnant women that it is unwise to take any medication unless there is specific medical advice to do so. I think that probably would be wise.
Yes, but then they were prescribed these...
But doctors were quite wrong, absolutely.
So sometimes one trusts doctors when...
Absolutely.
But then what is your belief about banning some of these chemicals that are used for other things that are dangerous in other circumstances?
Look, we use the motor car. The motor car kills and maims thousands of people. Why don't we ban the motor car? We use drugs for comfort. We use drugs to try and treat unhappy illnesses. And that is a balance that many of us benefit, some of us suffer. But society has never worked out the ethics of this.
Talking, I don't know if this is your subject or not, but the continuation or the having brought out thalidomide once again to cure cancer,
yes,
AIDS,
myeloma, absolutely.
Myeloma,
Yes.
AIDS, and
in AIDS and in Eels disease in eyes, in one aspect of treatment of leprosy.
I've heard also acne. I don't know whether this is true.
Well, I think one would have to have very, very severe acne to recommend its use. My position in all these areas is this, that they are, and it's easy to understand why, complex and detailed recommendations of all the precautions that one needs to take. Anybody's knowledge of human beings is such that with all the precautions in the world, there will be some who will pay no attention. Therefore, if a dangerous drug is used, sooner or later, it will escape into the population and cause its damage unless there is the strongest possible control of the issue of this drug, so that it does not depend on the individual's observance of the precautions, but that it is simply not issued except under certain very limited circumstances. If it was only issued by licensed university centers, with each university center having an identified person responsible for the issue of the drug, responsible for the follow-up of how it's worked and how much of it has been consumed, that would be expensive. That would make the drug more expensive, and then there would be outcry that the drug is too expensive. Then there would be a reduction of cost with a reduction politically of the control, and we will be back to square one. But that is the way the world works.
But is thalidomide really curing these people, or of the illnesses we spoke of before?
This is a matter of contention in some cases, and I wouldn't have the expertise to judge. But certainly I've spoken to one person who claims that the usefulness of thalidomide in myeloma is only very marginal. Others dispute that. As in leprosy, there have been claims that the the observed improvement in some people undergoing treatment for leprosy is an illusion. Well, that's very difficult because it was so dramatic in the way it was discovered that at least some people must benefit. It is a very complex problem, and I think that all one can do is enforce precautions as best one can.
Okay, not ban.
Banning would simply lead to a black market. I think once a drug has been discovered, it cannot, and if its manufacturer is profitable, sooner or later it will be produced. And I think control is easier if it is not banned.
Going to another question. In Spain, nobody knows the quantity of tablets that were sold. Is this figure known in the UK?
Yes, and I don't have it offhand, but yes, we were able. Well, my information comes from the attempt to write a book many years ago, and the attempt is still lying in my study, unpublished. But yes, we calculated the total amount of drug tonnage that was produced. We then compared it to the the population numbers. How many of those were men, how many of those were women, how many of the women would have been pregnant at any particular time, and then of those who were pregnant, how many might have been taking it in the early months of pregnancy. And a very rough comparison became possible.
Okay. Distillers themselves gave you the figure of tablets, or?
And we got this from distillers and from public health sources and from a wide range.
For some unknown reason in Spain, they're unable to get these figures.
Well, it's only if figures are created at the time, and then if they are kept, if archives are kept for a sufficient number of years. Many people, through lack of space and so on, destroy archives maybe 10, maybe 15 years after the event, without any sort of political skullduggery in mind. I think this now, it's 50 years after the event, and it is a very long time.
Sorry, I just need to study a few minutes. What other questions are probably important to get from you?
Your arm must be falling off.
I think we've covered nearly everything, except maybe talking a little bit about if you've followed the victims. Are you ready?
Yeah.
Sorry.
hemorrhage.
Yeah, if you've looked after the thalidomide people since they were children up until a later, until you worked, I think, basically, didn't you? And have you seen great deterioration in their health by straining other parts of their body?
Well, their health pattern at first was really very reassuring. Nobody knew whether thalidomide would yet cause unexpected changes as they grew into adults and then early adult life. And we were very reassured when, as the years went by, there was no suggestion. For instance, one might have said, would they have any more malignancies than other people or more heart disease than other people? And the answer is no. They were spared that. But because the anatomy of their bodies is different, and because the human arm and the human leg, the way it is ideally adapted to the muscles and tendons and nerves and so on that action it, in thalidomide this is not the case. And therefore there's much more severe use of the spinal joints, and or the shoulder joints particularly. When you think of somebody with short upper limbs, then clearly you have to lean forwards and yet maintain your balance where you're standing, whether you're in a seat or whether you're standing on your legs. And that is probably the major reason for the unduly rapid deterioration. As far as the spine is concerned, there were some thalidomide spinal abnormalities as well, of the discs and of the vertebrae themselves. So that was then an additional feature. For the shoulder, again, anatomically abnormal shoulders. So it's not surprising that things that many people suffer as they age is now taking place earlier. The only sort of analogy other than aging you can think of is ballet dancers, that you may have an unduly severe or early hip degeneration in ballet dancers because the actual wear and tear on the hip is greater than normal.
And
so that is undoubtedly happening.
What about their interior organs? Are they deteriorating faster?
Well, yes, if there is a thalidomide-determined abnormality of the kidneys, then you may have deterioration of kidney function. Liver, no. Obviously, if you're an alcoholic, you will have liver damage, but not outside that. Brain, no advanced brain deterioration. I think they're spared that.
Okay. One thing I just remembered, one of the British women I interviewed yesterday mentions that was quite a lot of them had visible nose. They were quite recognisable due to their noses.
Yes. The rather broad bridge of the nose, with the nostrils more or less pointing forwards, this was quite marked when they were very young, much less marked as they've got older. Some had very specific nasal abnormalities, like that one nostril, say, wasn't joined to the back of the throat, and that needed surgery. But the nasal deformity, a lot of their faces are very comparable, and if that facial impact is there. But it's by no means there with every thalidomide sufferer.
Because it depended on the period their mother had ingested.
Exactly.
Okay.
That was time-related also.
Could you please explain the method of assessment that you go through, or you went through in Britain, and you would recommend other people do?
Yeah. Well, the method that was used in UK evolved, and I would recommend it because it seemed to work pretty well. I wouldn't be so arrogant as to say it's the only possible method, but it is certainly one that worked quite well.
Could I just ask you, do you know anything about the method they also did in Germany, Sweden and other countries?
Yes, indeed.
Were they very similar?
They were broadly similar, but the exact organisation of which doctors participated that differ to some extent. And one has to say that the medical profession in Sweden, for example, was considered by a number of authors to have been partly responsible for the delay in taking thalidomide off the market. So one cannot always assume that every professional is necessarily on the side of on the side that they should be. No, that's an aside. What is clearly necessary, in my opinion, is this: to recognize that evidence of ingestion is hard to come by and will still be available in only a very small minority of individuals, and that it would be therefore totally unfair to demand written evidence or even sworn testimony in order to determine whether somebody may have taken a drug or may not have taken the drug. There is a lot of evidence to show that memory was very deceptive, and in the method that we adopted in this country, Professor Richard Smithles, who did a lot of the assessment in the early days, and others like him and myself, took the view that if conception took place at a time when thalidomide was available, either by prescription or over the counter, then there was at least the possibility that it had been taken. Now, it is known by the pattern, the way the drug works, that if it is taken very early in pregnancy, it has no ill effect. And if it is taken after the sensitive period is finished, which is about 55 days or so after the first period, first day of the last period, then again it has no effect. But that if it is taken during the sensitive period, then there is virtually 100% risk of some type of thalidomide consistent abnormality. So therefore, one has to accept the possibility of a thalidomide effect if there was conception at a time when the drug was available. The next important topic obviously has to be the congenital malformation itself. This needs accurate anatomical description and needs to be complete. And then when that has been done, one has to compare that pattern with what is known about the effects of the drug. This is now 50 years since, so a great deal is known about the patterns. The patterns may even yet be incompletely described because no prospective trial was done at the time. It couldn't have been done because if people had known that thalidomide was damaging, one wouldn't have given thalidomide to 1,000 mothers just to see what happened. So we are still not entirely sure about all the different things that thalidomide can do, but we are pretty sure of much that it has done. So one would first of all determine when an individual had been conceived. The next duty would be to decide exactly what congenital malformations the individual was born with, and that is of course before any surgical intervention with removal of abnormal limbs and so forth. One needs to determine what the pattern was at birth. Then there's a comparison with known patterns of abnormality, and the next steps then depend on the motivation of the examination. There are some thalidomide compatible patterns that may be due to genetic conditions. In the English cohort, although they were recognized even at the time, they were ignored. That, I think, is in many ways a very humane attitude, but it is not necessarily one that would necessarily be adopted. So that is then at the end of the assessment. Otherwise, one might add a genetic assessment as well. But it would materially increase the cost. And having found those facts, I think it will be fairly clear who was then more likely than not to be a thalidomide victim, and who was less likely to be a thalidomide victim, and others who were undoubtedly not thalidomide victims. Those would be the categories that one would find at the end. And finally, of the group that were adjudged either likely or certainly thalidomide victims, there was then an assessment of severity, and the method, the MAP method, that's the medical assessment pattern, a medical advisory panel, MAP, medical advisory panel method, served very well and could still be activated again.
Okay. There is one question that I have been a bit embarrassed to ask some of the victims themselves, because I find it quite highly personal, but perhaps you could answer that. Where there are obviously things that for them has been very difficult in life, like going to the loo, or things that we automatically think of, dressing oneself. And are there any other things that you could perhaps make the viewer aware of? That?
Well, there certainly some have difficulties in intercourse because of abnormalities of the external genitalia. Some have an impossibility of reproducing because there may have been a uterine abnormality or a disconnection either between the testes and the penis, or a disconnection between the fallopian tube may be blocked or absent. And so sterility or seriously impaired fertility is an additional problem. And they have also, some had severe rectal problems which required surgery, and those have continued difficulty in going to the toilet if there's been any narrowing there or any other failure or function. So it has been a very pervasive and a very extensive area of abnormalities, including these ones for personal care and for reproduction.
Imagine just the everyday going to the just going for a pee.
Absolutely. If mobility is severely impaired or is painful and so on, then all these things add up to a very, very severe impairment of life.
And I think it's important that people realise it's not just what you see.
Absolutely. Yeah.
There's all the other very embarrassing and humiliating things they have to live with every day.
One thing I haven't mentioned in this, for instance, in the men, there are some particular ones with very severe lower limb deficiency. They have retained testes in the abdomen, and there is an enhanced risk of malignancy.